All right? Another way that Kevin may teach you that is if you are working this formula here, okay, well, this is the second portion of the arterial oxygen contents. Well, PaO2, my God, even if your PaO2 is 900, you multiply by 0.003, you got nothing. So the addition of this product here to this number here is not going to be a whole lot of difference anyway. So by the time you multiply your hemoglobin by 1.34 and by your O2 saturation, if you look at the options, you will see an answer that is very close to it. You don't even have to worry about that, okay, unless you just want to be exact. Okay, so that's another thing they're going to teach you. Any questions about that? So I may have you calculate this on your quiz tomorrow. Okay? So we got an example there. Oops, sorry. Okay, so now oxygen hemoglobin curve is a curve that establishes a relationship between PaO2 and oxygen saturation. That's all. It is a curve that establishes a relationship between PaO2 and O2 saturation. In other words, if you have this amount of PaO2, what would be your O2 saturation? If you got this amount of PaO2, then what would be your O2 saturation? Okay? So now, before I show you that curve, what the curve says is that as you increase your PaO2, your O2 saturation increases. Well, that makes sense. The more oxygen that you have dissolved in the plasma, the more the hemoglobin is going to pick up. Because we're looking at hemoglobin saturation. Okay? But once you get to a PaO2 of 60, okay, any addition in PaO2 will not necessarily improve your oxygen saturation. So in essence, you may have a patient that has a PaO2 of 65, their O2 saturation is 100%. You may have a patient that has a PaO2 of 80, their O2 saturation is 92, okay? You may have a patient that has a PaO2 of 78, their O2 saturation is 95. So all it says is that as you increase your PaO2, your O2 saturation increases until you get to a PaO2 of 60. Then any addition in the PaO2 after 60 will not necessarily improve your oxygen saturation. So in essence, all you really need to get O2 saturation of 90% or more is 60. Period. 60 PaO2. Okay. All right. So to that now they have what they call the 4, 5, 6,
Thank you.
7, 8, 9 rule. 4, 5, 6, 7, 8, 9 rule. Because now they're gonna go like on the exam they may say, well, a patient has a PaO2 of 40. What would you expect their oxygen saturation to be? Okay? So this rule here kind of helps us out a little bit. So if your PaO2 is in the 40s, your O2 saturation will be in the 70s. If your PaO2 is in the 50s, your O2 saturation will be in the 80s. And if your PaO2 is in the 60s, your O2 saturation will be in the 90s. So they say, well, they have a PaO2 of 65, what will be their oxygen saturation? You find an answer that is in the 90s and you pick it. Okay, 4, 5, 6, 7, 8, 9 rule. All right. The next thing is that hemoglobin has a natural tendency of attaching to oxygen. Okay, it has affinity for oxygen. Oxygen will attach to the hemoglobin once it's exposed to oxygen. but also it has affinity for carbon dioxide and carbon monoxide. Okay? The affinity of carbon dioxide and carbon monoxide to hemoglobin is more than that of oxygen. So carbon dioxide and carbon monoxide will quickly attach to hemoglobin before oxygen will have the chance to attach to it. Okay, so carbon dioxide has 20 times more affinity to hemoglobin than oxygen. Carbon monoxide has 200 to 240 times more affinity to hemoglobin than oxygen. So in other words, if I have two tanks here, I have carbon monoxide tank and then I have oxygen tank. Somebody walks into this room, immediately they're going to have shortness of breath because their hemoglobin will quickly attach to carbon monoxide, not giving oxygen any time to attach to it. Okay, that's what we call the carboxyhemoglobin. Okay, and the same thing if you have oxygen and carbon dioxide, somebody walks in here, they're going to have shortness of breath because carbon dioxide will quickly attach to their hemoglobin before oxygen gets the time to attach. Okay, so that's what we mean by affinity. All right, and then the attachment of carbon monoxide to hemoglobin will usually result in hypoxia. Because you see, once the carbon monoxide attaches to the hemoglobin, then the hemoglobin cannot carry oxygen down to the tissues. Okay? It cannot carry oxygen down to the tissues. All right? So, how do we treat carbon monoxide poisoning? 3 ways. Okay. How do we give 100% oxygen? How do we give it? Non-rebreather is one. What else? Hyperbaric chamber is actually another one and the best. And then 100% CPAP. Okay. So in treating that, what we look at when we're treating that, if we want to know that the patient is okay now, we look at oxygen saturation. If I'm giving them 100% oxygen, I want to build up a lot of oxygen pressure to drive away the carbon monoxide molecules from the hemoglobin. And then if the hemoglobin now has like 95% saturation or above, then that would mean that there is not a whole lot of carbon dioxide attached to it. So that's what we look at, not the PaO2. Okay, because on the exam, when you get this kind of patient, they will say, well, the patient has a PaO2 of 500. Okay. But then you look at the O2 saturation, it's 79%. You should not discontinue oxygen therapy. You shouldn't. Okay? You have to wait, give them more oxygen, until that O2 saturation is 95% or above. Okay? That would mean that all the carbon monoxide molecules are gone. Any questions? Yeah, so this is the curve here. So this is the normal one here in the middle. Okay. So like now, this is my, this PaO2 here. PaO2 is horizontal, and then oxygen saturation is vertical. So PaO2, okay, I'll come up here. My oxygen saturation will be about right here. Okay. For that PaO2, I'll come up here. My oxygen saturation will be right here. And then see this one here, 27. Okay, my oxygen saturation is about right here. Now you all remember seeing like at the P50 and those are chemical simulation, P50. I told you never to pick it. Okay, so that's the P50 here. So P50 is the partial pressure of oxygen at which the hemoglobin is 50% saturated. That's what that means. Partial pressure of oxygen at which the hemoglobin is 50% saturated, and that PaO2 is 27. So P50 is 27. Okay? All right, so we'll go over here. Now PaO2 is there. Oxygen saturation will be about right here. So as you keep on increasing your PaO2, your oxygen saturation increases until you get to a point like right here. Now there is a plateau on that curve. Okay, it kind of goes like that. Okay, it's a plateau. So that means then that any addition in the PaO2 after 60 will not necessarily improve your oxygen saturation. That's what we're saying. Okay? All you need to get O2 saturation of 90% is a PaO2 of 60. You don't really have to have any. Okay? Any questions about that? Okay, so now, sometimes now, this normal curve here can shift to the right or shift to the left, depending on what the patient has. Okay? Now, a shift or right shift means decreased affinity. The hemoglobin is turning loose the oxygen and the carbon dioxide attached to it. That's what that means. Decreased affinity. Okay? Increased affinity means that the hemoglobin is holding on very tightly the oxygen, okay, that is attached to it. Okay. Certain conditions will cause the hemoglobin to hold tight to the oxygen. Okay. Certain conditions will cause the hemoglobin to turn loose the oxygen attached to it. Okay? So, let's look at the factors that will cause decrease or increase affinity. Okay? Low pH. Okay, low pH, less than 7.35. That's acidosis, right? Acidosis will kill your cells. Okay? When that happens, the body knows to quickly tell the hemoglobin to release all the oxygen attached to it. Okay? CO2, high CO2, well, high CO2 is low pH. So if you have high CO2, then there will be decreased affinity because you're very, very acidotic. If you have high temperature, anytime you warm up the hemoglobin, it will turn loose the oxygen and carbon dioxide attached to it. Now, actually, when you're doing your blood gas, you're supposed to check on the patient's blood temperature, body temperature. Okay? You're supposed to. Because the blood gas analyzer analyzes our body temperature, 37 degrees. So if my patient has fever, and I analyze the blood gas at 37 degrees, that will be wrong. Okay? So if a patient has fever, you got to tell that blood gas analyzer, this is the patient's body temperature now. Because if you don't, it will assume that the body temperature is normal. Okay? So when you tell the machine, well, this is the patient's body temperature now, after it has finished analyzing the blood gas, it will print you out 2 columns of results. It will say, well, this is what the blood gas would have been if they did not have temperature. This is what it is with temperature. Now, let me tell you this. Now, for instance, now, let's say that my patient is febrile, okay? The hemoglobin warms up and releases the carbon dioxide and the oxygen attached to it. So in that blood gas, when you run it at body temperature, PaO2 will be higher than normal. Will be higher than normal. PCO2 will also be higher than normal. Now, the doctor comes in and then looks at the blood gas, while the CO2 is 55, for instance. And he goes, well, I think we need to intubate this patient here. Not knowing that you ran the blood gas as if the patient did not have temperature. Okay? If you had put in temperature, you would have had a corrected value. The machine corrects for temperature. A good respiratory therapist ought to be doing that, because everybody is in a hurry and they want to they don't think about the patient's body temp. All you gotta do is look at the nurse's notes and get the most recently taken body temperature. And if you analyze the blood gas, when it comes up, say, well, what's the patient's temperature? You put it there. But if you are going to send the blood gas to the lab for them to analyze, also you tell them that this is the patient's body temperature. Okay? Any questions about that? Okay? So on the exam, they said if a patient has fever, how would that affect the blood gases? Well, the gases in the blood gas are oxygen and carbon dioxide, period. Well, it will make their PaO2 to be falsely high. It will make their PCO2 to be falsely high as well. Okay? And then we have increased DPG. Let me try that. DPG stands for Albert. I'm definitely having Parkinson's disease here. Right, Kara?
No. We're allowed to have off
Yes.
days. It's okay.
Huh?
We're allowed to have off days. It's okay.
Okay. Well, I'm glad you said that. Sometimes I worry about myself.
I do too. No worries.
That's broken now. Okay. All right, so DPG stands for diphosphoglycerate. That's the way they spell it. It's glycerate. Now, this is a substance that is made in the red blood cells. It's inside the red blood cells. What it does is to help the oxygen to transfer from the red blood cells to the tissues. That's what it does. Fix this for me, please. What it does is to help transfer oxygen from the red blood cells to the tissues. Okay? When you have normal oxygenation, normal level of oxygenation, the level of it is good. Okay, you have normal level. But when you have hypoxia, okay, the level of, is it going? Maybe it's broken. It's okay if you can't fix it. When you have hypoxia, it goes up. Okay, thank you then. Yeah, when you have hypoxia, it goes up. Okay, so that causes the hemoglobin to have decreased affinity, release more oxygen. Okay? Any questions about the factors that will cause decreased affinity?
I have a
This is
question.
like first semester stuff here.
For the decreased affinity, does this go for both O2 and CO2 every time, or is it
Yes, yes.
Okay.
O2 and CO2 every time.
So even for the DPG,
Yes.
that would be decreased affinity for CO2 as well?
Correct.
Got it. Thank you.
Yeah, because you see, both oxygen and carbon dioxide attached to the hemoglobin. Like if you get oxygenated blood, you have CO2 in it, but not as much CO2 compared to the oxygen. If you have deoxygenated blood, you have more CO2 than you have oxygen. Okay? That's the way it works. All right, so now, the next one is what factors will cause increased affinity where the hemoglobin will hold on to the oxygen very tightly and not want to let it go? High pH. Well, high pH, they are ventilating. Okay? There's no reason to lose a lot of oxygen. And then low CO2, well, low CO2 means high pH. Low body temp is opposite to high body temp. Okay? Again, if a patient has hypothermia, okay, they have low body temp. When you run your blood gas, you put in your temperature. Okay? Otherwise, you will get a falsely low gases. Your PaO2 and your CaO2 will be falsely low. Okay? And then, of course, decrease 1, 2, 3 DPG. Okay? Fetal hemoglobin, that's why babies don't need a whole lot of oxygen. Fetal hemoglobin. You have your fetal hemoglobin for a while before you convert to an adult type of hemoglobin. So the fetal hemoglobin has increased affinity to oxygen. It holds the oxygen very tightly. Okay? And then we have carboxyhemoglobin. Okay? We have carbon monoxide attaching to the hemoglobin. That will cause the hemoglobin to hold tight to the oxygen. Okay? Any questions about that? Now, the next thing here is oxygen transport. So it says that oxygen transport or oxygen delivery, okay, is the flow of oxygen to the tissue cells. It is determined by the body's ability to oxygenate, hemoglobin concentration, and the cardiac outputs. Okay. So now this is the way I look at oxygen transport. When I think about it this way, I remember it more. So here's your alveolus. Now you breathe in the air, you ventilate. Now the oxygen has to cross over the alveolar capillary membrane into the blood here, which will be oxygenation. And then binds to the hemoglobin. Okay, binds to the hemoglobin. And then the hemoglobin then transports the oxygen molecule to the tissue. Okay? Down to the tissue. At tissue level or cellular level, oxygen would diffuse into the tissues where it is used for metabolism. Okay? Of course, you know with metabolism we're producing energy, ATP. That's a form of energy for muscular activity. And then we're producing heat to maintain body temperature. And then we're producing CO2. Okay? So the CO2 comes out, okay, and then goes back to the lungs to get in here and go out. So oxygen transport is nothing but the delivery of oxygen to the tissues. That's all. So on the exam, they may call it oxygen transport or oxygen delivery. So now, oxygen transport is represented by symbol DO2. DO2 is a symbol for oxygen transport or oxygen delivery. Now, we're going to do normal plus normal equals normal, okay? To find out what normal oxygen transport is. So we have a cardiac output, normal is 5. We have CaO2, normal is 20. And then the 10 is a constant, okay? The 10 is a constant. To convert that unit to milliliter of oxygen per minute, okay? So we get 1,000, okay? So normal oxygen transport is 1,000 milliliter per minute. So 1,000 milliliter of oxygen is what is delivered to the tissues in 1 minute. Okay? Factors that affect oxygen delivery to the tissues. Okay, so all the things here that you see, okay, cardiac output will affect it. The higher the cardiac output, the higher is oxygen delivery. The lower the cardiac output, the lower the oxygen delivery. CaO2 can affect it. The higher the CaO2, the higher the oxygen delivery, the lower the CaO2, the lower the oxygen delivery. But they don't make it that easy. Now, watch this here now. Cardiac output, this is what I'm looking at. DO2 equals the stroke volume times heart rate times hemoglobin times 1.34 times SaO2 plus PaO2 times 0.003. I opened it up. If a patient is having massive GI bleed, will the oxygen delivery to the tissues be high or low? Low. And then what is it affecting here? If you're having GI bleed?
Hemoglobin, stroke volume.
Right? That's the way they ask it, because he sees it that way. A patient is hypoxic. Their oxygen delivery will be high or low? Low. Oh, yeah. A patient has polycythemia. What's polycythemia?
Too many red
High
blood cells.
hemoglobin, right? Will the oxygen delivery to the tissues go up or go down? It will go up because you have more hemoglobin. See that? The patient has low stroke volume now, which would then cause low cardiac output. So oxygen delivery to the tissue will also go down. They have bradycardia. The oxygen delivery will go down. Okay? So some of these questions, they ask it indirectly. A lot of times, you can use the formula to answer a lot of questions. If you remember that formula and kind of open it up, it will give you the answer. Okay? Any questions about that? All right, so here's one that I've seen on a mechanical ventilation question. Okay? The respiratory therapist increased people from 5 to 10. Okay? And the cardiac output went from 5 to 3. The therapist will conclude that oxygen delivery to the tissues has decreased. I've seen that before. I like that question. Because when your cardiac output goes down, oxygen delivery goes down. Okay? So if you increase PEEP, and then you're told that oxygen delivery has decreased, that's another way of telling you that cardiac output has just decreased. Okay? All right. So here's where we did a calculation here. Normal plus normal equals normal. All right, so oxygen consumption now. Oxygen consumption is the amount of oxygen that the tissues consume or use up in 1 minute. So let's go over that again. Oxygen delivery is the amount that is delivered to the tissues. Oxygen consumption is the amount of oxygen that the tissues actually used from what was delivered. Okay? So, the normal oxygen consumption is 250 milliliter per minute. Even though we sent 1,000 down to the tissues, actually 250 of that is actually being used. Okay? Now, we send the tissues extracted 250 out of the 1,000. They used it for metabolism, and then they produce CO2 as byproduct. So normal CO2 production in 1 minute is 200 milliliter per minute. So we're using up 250 of oxygen, then we're producing 200 of CO2. Okay? There's something called the respiratory quotient. Respiratory quotient. The ratio of the CO2 produced to the ratio of, the amount of CO2 produced to the amount of oxygen consumed, which is 0.8. So normal respiratory quotient is 0.8. If you want to, you can call it normal VQ matching. Normal VQ matching is supposed to be that you use up 250 of oxygen, you produce 200 CO2. That's normal. That's the way it's supposed to be. Okay? If you're producing more CO2 than 200, then that's not good. Okay? If you have less oxygen than 250, then that's not good. That's VQ mismatch. And that will be VQ mismatch. Okay, that's normal matching. All right, so now, to calculate the oxygen consumption, you also use the Fick equation, the same formula. So here is the Fick equation here now. That's actually the Fick equation rewritten in another way. QT equals oxygen consumption divided by arterial to venous oxygen content difference times 10. That's Fick equation. But now I want to solve for oxygen consumption. So I'm going to cross multiply that way. So I go cardiac output times arterial venous oxygen content difference times 10 equals cardiac output equals oxygen consumption. So it's the same formula. So now, if we did normal plus normal equals normal, we would come out with 250. So, cardiac output is 5 times arterial to venous oxygen content difference is 5 in the middle, that's normal. Range is 4 to 6 times 10, that ought to give you 250. Okay. All right. Any questions about oxygen consumption? Now here's an example that I gave to you. I'm asking that you calculate oxygen consumption here. Cardiac output is given as 5. Arterial venous oxygen content difference is given as 6. It's acceptable but it's not normal. So you work that out, you get 300. So that means that with oxygen consumption, we have a range as well. Everybody cannot be 250, you know? Depends what you're doing. If you move around a lot, you use more oxygen. If you have more muscle, you use up more oxygen. So we have a range, okay? Oxygen consumption will go up when you're exercising. Okay, if you're exercising, your body is using up more oxygen. You consume more oxygen. All right, so here's another one. Here we're doing the cardiac output here. So we're doing the Fick equation here. You're gonna do this tomorrow. So put your oxygen consumption on top, which is 240. Arterial to venous oxygen content difference. Well, I gave you the CaO2 as 17. I gave you the CVO2 as 12. So you subtract 12 from 17, that will give you 5. Okay, so that will be your gradient there. So you put 5 there, okay? And then you multiply by 10, that's 50 divided by 240 divided by 50. And then your cardiac output is 4.8. Is that a normal cardiac output? Yeah, that's normal. That's normal. Any questions about how to do the Fick equation? Factors that affect oxygen consumption. What are the things that can cause you to use up more oxygen than the 250? Exercise. Yeah, when you exercise, you use up more oxygen. Okay? Seizures. That's involuntary contractions of the muscle. Okay, every muscle needs oxygen. So if you have more muscle at work, you expend more oxygen. Shivering. Now, shivering is whenever you shiver like that, you've just undergone metabolism. If you go out in the cold and you do this, okay, right, like electric shock, right? Oh, somebody shot him, you know. You are trying to create body heat because metabolism produces body heat. That's why we shiver, okay? You're trying to create the body heat to maintain your body temperature. Okay, so if you're undergoing metabolism when you're shivering, then you are using up more oxygen because you got to have oxygen for metabolism. All right? Now, in the wintertime, I see people shivering, I'm like, oh my God, are they dying or what? Even with the winter coat. All right, hypothermia. Hypothermia, think in terms of fever here. Okay, infection. Fever is a sign of infection. Infection demands more oxygen. When you have infection, your cardiac output should go up because the body calls for more oxygen. Okay, so that will make you use up more oxygen. Factors that will cause oxygen consumption to decrease. Skeletal muscle relaxation. Well, that's true. You're sitting still, you're not moving around. There's no reason why you should be using up more oxygen. Okay? Certain poisons. That is true, because now the poison prevents uptake of oxygen by the hemoglobin. That's why people die of poison. When they poison you, the hemoglobin cannot take up the oxygen. The body cannot take it either. So they die of hypoxia. That's basically what poison do to people. Hypothermia, low body temp. Yes, if you're wondering why people can be submerged in water for a long time, or maybe people that went to, what do they call it, like, is it hiking or something, where cold weather, People go out, what do they call it, hiking, like in the mountains? Yeah, those people, sometimes something happens, they get trapped somewhere, and then they're still found alive, despite all that cold weather. That's why they stay alive. Their body doesn't need to use up a whole lot of oxygen. Okay? Any questions about that? Okay, so the next thing is oxygen extraction ratio. The amount of oxygen extracted by the tissue cells divided by the amount of oxygen delivered. So now, look at this now. We sent 1,000 milliliter. How much of it is actually extracted by the tissues? It's 25%, which is the same thing as 250 milliliter. So extraction ratio, in essence, is the same thing with consumption, other than the extraction ratio is expressed in percentage. If you multiply 25% by 1,000, you get 250. But we call it the extraction ratio is 25%. 250 consumed. And here's the formula there. So let's do normal plus normal equals normal. Arterial oxygen content is 20. Venous oxygen content is 15, divided by arterial oxygen content, which is 20. That gives you 25%. 25% is the extraction ratio. Factors that affect oxygen extraction ratio. What would cause the tissues to begin to extract more oxygen from what was supplied? Decreased cardiac output. Yes. There's no more, the supply is short. When the cardiac output drops, the tissues will begin to extract more oxygen, even from the venous blood. Anytime the cardiac output drops, the tissues will begin to get more oxygen from the venous blood. The extraction ratio goes up. Okay, extraction ratio goes up. Periods of increased oxygen consumption. Anything that can cause you to use up more oxygen, exercise, seizure, fighting, beating up your wife, or your wife beating you up, those kind of things. Now, if you beat up a woman, you go to jail. You know that, don't smile about that. You go to jail. I would never try that. Would you try that, Ray? Please don't, because they're not going to have mercy on you. Women are America now, okay? Even when you get a divorce, they take all your stuff and then give it to the woman. See? So that way they're winning. All right, so, when did I start? Okay, yeah. So, decreased cardiac output, periods of increased oxygen consumption, anemia will cause that. You have low hemoglobin now, okay? Decreased arterial oxygenation, factors that will cause it to decrease. Increased cardiac output, where the supply is more now. So there's no need to take it, it's there, okay? You have more supply of oxygen. Skeletal muscle relaxation, you're not moving around a lot. Hypothermia, low body temp. Increased hemoglobin, yeah, increased hemoglobin. Now, like the COPD patients, because they have chronic hypoxemia. Always, they have chronic hypoxemia. Their body responds to that by making more hemoglobin, so that their oxygen carrying capacity can increase. So even on the exam, if they give you a patient that has a hemoglobin that is greater than 16, you suspect COPD or obstructive sleep apnea. Okay? Because their body just makes more hemoglobin to increase oxygen delivery to the tissues. Increase arterial oxygenation. Okay? All right. So now, when you run VBG, venous blood gas, these are the parameters that you're going to get. You're going to get your PVO2, your SVO2, your venous oxygen content. You're going to get the difference between the CaO2 and CVO2. And I told you before that VBG, okay, if you want to know how well the heart is working, you look at venous parameters. If you want to know how well the lungs are working, you look at arterial parameters. Okay, so doctors will use the VBG to assess the function of the cardiovascular system. Okay, so now PVO2 is the partial pressure of oxygen in the venous blood. Partial pressure of oxygen in the venous blood, just as the PaO2 is the partial pressure of oxygen in the arterial blood. The normal value for that is 35 to 45 millimeter of mercury. 35 to 45 millimeter of mercury. And most importantly is, when the PVO2 is decreasing, cardiac output is decreasing. When the PVO2 is increasing, cardiac output is increasing. Again, they come up with that mechanical ventilation question. In fact, we saw one the other day who were doing the same. They increased the PEEP from 5 to 10 or whatever. The PVO2 went from 39 to 33. That's another way of saying that cardiac output has just decreased. You're going to have to back up on your PEEP a little bit. Any questions about that? Okay? And then another thing is that they may use, if you remember the optimal PEEP, they may use PVO2 as complication. For instance, let's do optimal PEEP study now. We're trying to determine the level of oxygen, the level of PEEP that will give the best oxygenation without causing complications. Let's say we started with a PEEP of 5. We have compliance here. We have PaO2. We have PVO2. Well, the more, here's another thing. The more you oxygenate the arterial blood, the more you oxygenate the venous blood. The less you oxygenate the arterial blood, the less you oxygenate the venous blood. That's the way it works. Okay? So we started with a PEEP of 5. Compliance is 40. PaO2 is 60. PVO2 is 45, which is normal. That's normal. Well, I'm not pleased with a PaO2 of 60. I want to get more oxygenation for that patient. As a result of that, I increased my PEEP to 8, as we would expect, because PEEP improves compliance. Compliance went up to 48. PEEP improves PaO2. PaO2 went to 65. Now, we're talking about more PEEP here. That should put more pressure on the cardiovascular system. So the PVO2 should go down. Okay? Actually, let me do it the other way. I'm not confused. Let me do it the other way. Let me start with 35, actually. Okay, so now this went up to, let's say, 37. Okay, that's good. And we still got normal cardiac output here because this is 35 to 45. Okay, well, I'm not pleased with a PaO2 of 65, so I want to get it up. I go to PEEP of 10. Compliance will improve to 55. PaO2 will increase to 75. And this one here will go to like 39. Okay? Well, we still have normal cardiac output. So and this is not good. I want to get it to 80. So I go to a PEEP of 12. That goes to 60. That went to 80. And then that went to 37. Well, look, this is supposed to go up. Okay? It's supposed to go up because that went up. Like I said, the more you oxygenate the arterial blood, the more you oxygenate the venous blood. Even though that this is still normal, it's complication because it's supposed to go up. So what would be my optimal PEEP? This is my optimal PEEP. That is the level of PEEP that gave the best oxygenation without causing complications. Any questions about that? So they can do that. Now, another thing is that they can do it with SVO2, where the PVO2 is. They can put that there. They can put that there. And they can put that there. Okay? So you got to know the normal limits. All right, so now we'll go to SVO2. Venous oxygen saturation. The amount of hemoglobin saturation in the venous blood. It's not as much as the arterial blood. The hemoglobin will have more saturation in the arterial blood than the venous blood. Normal level is 65 to 75%. But what they really call normal is 75%. Isn't that crazy? If you look at the review books or your go portion, 75%, but the range is 65 to 75. Again, they can come at you with that. You went up on the PEEP, and then SVO2 dropped. That's another way of saying that cardiac output dropped. The higher the SVO2, the higher is cardiac output. The lower the SVO2, the lower the cardiac output. Okay? And then we go to a CVO2, venous oxygen contents. The total amount of oxygen in the venous blood. What is dissolved in the venous blood plus what the hemoglobin in the venous blood is carrying. That's what that means. You can see now that it's the same formula with the CaO2, other than if you look very closely, this is replaced by arterial oxygen saturation. And here, instead of the PaO2, we have PVO2. That's the only difference between that formula and this one here. So if you want that out, normal plus normal equals normal, you're going to come out with a number between 12 to 16. 12 to 16 volume percent. Okay, but now, what they call normal is 15. 15 is what they call normal. The range is 12 to 16. All right? If the CVO2 is decreasing, cardiac output is decreasing. If the CVO2 is increasing, cardiac output is increasing. Here's an example there. Okay, so you can look at that. Compensatory mechanism for poor tissue oxygen transport. Anytime the oxygen transport decreases, cardiac output will increase. Okay? increase in oxygen extraction ratio. Yeah, extraction ratio goes up because now the tissues will begin to get more oxygen from the venous blood. The tissues will begin to get more oxygen in the venous blood. Okay? So here's that extraction ratio. Extraction ratio equals, I can CaO2 minus CvO2 divided by CaO2. Now we started with 20 here, and then cardiac output goes down. The tissues now will begin to get more blood from the venous blood. Therefore, the amount of oxygen in the venous blood will drop. So instead of 15 here, we have 10. Because now the tissues are pulling it from the venous blood. Divided by 20. Okay? And what do we have for that? 50%, right? 50%. I think that's what we did. The extraction ratio goes up to 50%. Okay? Polycythemia. Okay? More hemoglobin than normal. Okay, the body will make more hemoglobin. Okay, to carry oxygen. That's the way our body compensates for that. That's exactly what the COPD patients do. They have polycythemia because they are always chronically hypoxemic. Shunts. Okay. You say that shunt, the percentage of cardiac output that moves to the right, to the left side of the heart without being exposed to alveolar oxygen. That is true. Okay. We have 3 veins. Anytime we pump our blood from the right, when you pump out blood from the right, it's supposed to go through the pulmonary artery to the lungs to pick up oxygen. But you have 3 veins where some of that blood pumped out will go into without making it down to the lungs. You have your bronchial vein, you have your pleural vein, and then you have the digestion vein. Those 3 veins are responsible for the 5% shunt. 5% of your cardiac output never makes it down to the alveolus. 5%. And it's because of those 3 veins. The blood will flow into them. So that's why we say that normal shunt is 5% or 4 to 5%. Now, this is the shunt equation here. Now, up till now, what you have been doing is estimated shunts. Well, this is clinical shunts. Clinical shunts. Now, estimated shunt is like 8 to 8 gradient divided by 20. That's what you've been doing for Mrs. Powell. But on the exam, they may ask you to calculate shunt, clinical shunt, using this formula. And you'll be really crazy to try to work that formula on the exam. But that would take you, you're doing it fast, it will take at least 5 minutes. I won't even try it, but there is a way to estimate that. And how would you know what they want you to calculate? Well, if you look at that formula, you're going to see here, this thing here, when you open it up, will have hemoglobin in it, it will have PaO2 in it, it will have O2 saturation. Open that one up, you're going to have your SvO2, you're going to see your PvO2. So when they start giving you those kind of values, then you know they're talking about this formula, not the 8 to 8 gradient divided by 20. Okay? A to A gradient divided by 20, the way we do it, right, we calculate the alveolar A equation. We use our alveolar A equation to calculate the P big A O2. We take away the P small a O2 from it, and then we divide by 20. That's estimated shots. All right, so what we're gonna do is, actually, these two formulas here are the same. Okay, I tend to remember it more when it's written in front of the first one. Okay, that's the one I remember the most, but either one should work. Okay, so what we're gonna do is we're going to calculate a clinical shunt using the formula, and then I'll tell you how you can estimate it without doing the calculation. Okay, so right here we're going to calculate shunt here using that formula. QS, percentage of shunted cardiac output, that's what that means, QS, shunted cardiac output, divided by QT equals A to A gradient times 0.003 divided by arterial to venous plus A to A gradient times 0.003. Okay? So our A to A gradient is given 200 on top times 0.003 divided by, well, we have that's given as well. Sometimes if they want to be very tricky, they will give you like this. CaO2 equals 17, CvO2 equals 15. Well, all you gotta do, you take away the CvO2 from CaO2, you're doing the same thing. But yeah, they give it to you. So that's better. So I go 3.6 plus 200 times 0.003. All right. Kira, what's 200 times 0.003?
.6?
0.6 on top, 0.6 divided by 3.6 plus 0.6. So we have 0.6 divided by 4.2, right? What's 0.6 divided by 4.2? 0.14 times 100% because we're going to put it in percentage. So what we have is 14% shunt. How long did it take me to do that? Well, sorry, you don't have to do it. Still, it will take you more time. But now look at this here. I want to estimate the shunt. I want to estimate that on the exam. Everybody has normal shunt of 5. Everybody, whether you like it or not, God gave you that, whether you like it or not. For every 100 millimeter of mercury of A to A gradient, there is a shunt of 5. Now think about that estimated shunt. If you divide 100 by 20, you got 5. So, if I want to estimate the clinical shunt then, and my A to A gradient is 200, then I'll go, well, for every 100 millimeter of mercury of A to A gradient, if there is a shunt of 5. Well, the 200 is a shunt of 10 then, plus my own shunt of 5. That's 15. Is 15 not close to 14? Now, on the exam, if they give me options, 14 and 25, and then 35 and 40%, and I estimated 15, there's absolutely no reason why I should not pick 14. That's very close. Now, if I was given a shunt of 300 instead of 200, excuse me, A gradient of 300, then I'll go for every 100 millimeter of mercury of A gradient, there's a shunt of 5. Well, the 300 will be a shunt of 15 plus my own shunt of 5. That will be 20%, right? How about if I'm giving 100 A gradients? So I have a shunt of 5 plus my own shunt of 5, that's 10. How about if I was given 50 A gradient? What would my shunt be with 50 millimeter of mercury A gradient? What would be my shunt if I was estimating? 7.5. 7.5, very good. Because 100 is 5, therefore 50 is 2.5 plus your own shunt. There's another way that you can do that as well. You can do it like what the guy in your review book says, portion. He says that, let's say we're doing 300 ATA gradient. So you take the first figure in your ATA gradient, which is 3, you add 1 to it, which is 4, and then you multiply it by your normal shunt, in fact, which is 20. If we are doing 100, take the first number in your ATA gradient, which is 1, you add 1 to it, which is 2, you times it by your normal shunt of 5, which is 10%. Yeah, please don't waste your time trying to work this formula on the exam. You may not finish your exam. You have 160 questions. Okay? But if you have to work it, well, you know how to do it now, right? So we're going to review here. What is normal value for oxygen consumption? 250 millimeter per minute. What is normal value for carbon dioxide production?
200.
200 millimeter per minute. What is normal value for CaO2? That's acceptable.
18.
Normal is 20.
20.
What they call normal is 20, but the range is 17 to 20. How about the CVO2? What's normal value?
15?
15, yeah, 15. The range is 12 to 16. What is normal value for arterial venous oxygen content difference? 5, right? 5, but the range is 4 to 6. Okay. What is normal shunt? What is acceptable shunt? Ooh, I didn't take it down. Okay, now, acceptable shunt is 20% or less. 20% or less is acceptable level of shunt, but normal is 5. Okay? So unless you have more than 20% shunt, it's not really a big deal. Okay? Put it that way. It's not really a big deal until it goes above 20%. Okay? Now we're going to take a break.